Good afternoon, everybody. Thank you for joining the medical grand rounds today. I am Juan Guzman. I'm the CTU director at the Hamilton Hospital. I will be hosting the rounds on behalf of Dr. Assam today. Our topic, hemophagocytic lymphohistiocytosis, a diagnostic challenge. And I have the presenter who are PGY3s internal medicine at McMaster. Dr. Katherine Fuller, she's a PGY3. She received her bachelor degree in health science from Western University, completed medical school training at McMaster, and she will be pursuing a GIM fellowship starting July 2025. Dr. Marina Atalla is a PGY3 internal medicine and McMaster. She received her bachelor of health science from Mark as well, and completed her medical school training at the University of Ottawa in 2022. You'll be starting a cardiology fellowship at McMaster University in July 2025. And Dr. Siraj is a PGY3 internal medicine. She also graduated from the Bachelor of Health Science program of McMaster, but she obtained her MD degree at University of Toronto. And she will be going to Toronto again to pursue a hematology fellowship starting in July 2025. I welcome you to rounds, and floor is yours.
All right. Thank you for the introduction. So I'm Katherine, and I'm excited to be here today with two of my friends and peers, Sarah and Marina, and we'll be talking a bit about the topic hemophagocytic lymphohistiocytosis, a diagnostic challenge. And before we get started, we just wanted to start with a land acknowledgement. So McMaster University is located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. We're privileged to provide care on lands that Indigenous people have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. And this is just a look at our presentation overview and learning objectives. So we'll start off with a case presentation, then we'll go through some of the disease background, clinical manifestations and diagnosis of HLH. Then we'll talk about management and then kind of summarize at the end. And for our learning objectives, there's three main ones. The first is to understand the systemic manifestations and diagnostic features of HLH, to describe common causes and triggers, and then to review treatment options.
So we'll be starting off with the case presentation. So this is a 62-year-old gentleman who was transferred from a community hospital to ICU for hypoxic respiratory failure due to bilateral pleural effusions requiring chest tube insertion. He was profoundly anosarchic. He was delirious, and he had these recurrent fevers, not yet diagnosed. And he also had these elevated lactate that was not in keeping with vasopressor requirements. And hematology was initially consulted for thrombocytopenia. And when you look a bit more into the past medical history, so it's actually relatively unremarkable. He has a history of high cholesterol, GERD. He's an ex-smoker. He's on some statins or medications. He's on a PPI. There's no known drug allergies. In terms of relevant social history, he's from Sri Lanka. He actually recently traveled in the last year to Cambodia, Sri Lanka, Malaysia, India, and Ethiopia. And when you look a bit more at the previous charts and you get some information on the HPI, you find that, he has this 1 month history of sort of weakness, malaise, and progressive shortness of breath. He was actually seen in ED, and he was actually seen in GMREC multiple times for this presentation, but without a clear diagnosis, and he was always discharged back home. So he subsequently was admitted to hospital and then transferred to ICU given hypotension requiring brief pressors and hypoxic respiratory failure requiring Optiflow. And interestingly, his lactate was actually elevated at 9.5, even though he was off of pressors. He was transferred to the ICU at the site that I was working at for further investigations, and he had a very broad autoimmune and infectious workup, which was negative. And I just wanted to highlight here that, this is a patient that, at this site it was seen in MSICU, but certainly this is patient that could similarly present, at their St. Joe's, like step down, or any medical step down that can provide a higher level of care. And these generic and undifferentiated patients can really present in any setting, including in GIM and in the community. On physical exam, he was noted to be febrile. He had a temperature of 38.5. He was a little bit tachycardic. His heart rate was 110. He was 40% on Optiflow. His pressure was a little bit soft, but his MAP was 64, was above 16, and he was off of pressors. And on exam, he was noted to be really profoundly anosarchic, like 3+ pitting edema up to the sacral region. He was profoundly delirious. There was no palpable lymphadenopathy or hepatosplenomegaly, and there were no changes that was noted. And this was sort of his initial blood work that came up. So his hemoglobin was 88. It was normocytic, but when you look back at his previous blood work on Clinical Connect, his previous hemoglobin was in the 120. So this is a new drop. He had a normal white count, but with a bit of a lymphopenia. His platelet count was low, so it's 29 from 105 previously. And when you look at this smear, you see evidence of what we call a leukoerythroblastic reaction with nucleated red blood cells in a left shift. And you typically tend to see this either, in states of high stress where your bone marrow is trying to push out cells, or if there's something in the bone marrow sort of pushing out the cells into the bloodstream. So you see sort of early progenitor cells that you typically see in the bloodstream. So his reticulocytes were elevated. He had positive hemolytic markers. So his LDH was elevated in the 800s. You might be able to argue it's not very specific. LDH is often elevated in a lot of different conditions, and especially in critical illness. But his haptoglobin was undetectable. He also had other evidence of sort of, like critical illness. He had toxic evacuation and granulation of his neutrophils. And there was actually some evidence of mild fragments on his smear. His INR and PTT were elevated. His fibrinogen was a little bit low, and he had a high D-dimer. So this was all suggestive of some underlying component of DIC, or disseminated intravascular coagulation. He also had elevated sort of liver enzymes, as well as a mixed unconjugated and conjugated hyperbilirubinemia. He had a mild AKI. His ferritin was in the 3000s range, so not super impressive, but elevated. His triglycerides were also elevated at 5, and on repeat blood work, his lactate is now 11. He had a whole bunch of sort of blood work that was sent off, and preliminarily some of the main ones, including Adams TS13 and some of your anticardiolipin beta-2 glycoprotein 4, your antiphospholipid syndrome came back negative. So, and as usual, with our sort of very generic undifferentiated patients, usually on GIM, we have like a trifecta involved, which is hematology, rheumatology, and IED, and they all sent off a very extensive workup, all of which was largely negative. He did have something called an EBV PCR, which was positive, but less than 1,000, so not very impressive. He was pan-scanned, and his CT noted he had a bulky spleen. So there was features of splenomegaly, and there was evidence of splenic infarcts, but there was actually no other lymphadenopathy noted. The CT also really showed evidence again of diffuse subcutaneous edema and also ascites. He got a TEE done, and it showed maybe there was a vegetation actually on the anterior mitral leaflet. And then he got an MRA brain done because he was profoundly delirious, and it actually showed evidence of multiple embolic strokes. And so this is kind of what, was going on in my brain when I saw this patient, whether it's with my hematology hat on, with my GIM hat on. There's clearly a lot of stuff going on in this patient. He's very undifferentiated. There's evidence of fragments and DIC. Is this an underlying microangiopathic hemolytic anemia? With the vegetations and these embolic strokes, are we dealing with endocarditis? He had recent travel outside of the country. The elevated lactate, despite vasopressor requirements, makes you think about like a type B lactic acidosis, where you actually use the anaerobic pathway. And it makes you actually think about certain types of cancers, particularly lymphomas actually use this pathway. And so you see this elevation of lactate, but they're actually not profoundly hypotensive. And that's actually called the Warburg effect. So that was kind of on my mind. With, again, the embolic strokes and the vegetations, with negative blood cultures, we thought about CAPS. Is this profound liver failure driving, the normal coagulation parameters? And could this be HLH? So all of these things were kind of on our mind. So
All right. So I don't want to spoil the case, but we are going to talk a bit more about HLH, which HLH again stands for Hemophagocytic Lymphohistiocytosis. And it's a syndrome of excessive inflammation and tissue destruction that occurs due to abnormal immune activation. And when we think about the pathophysiology of HLH, in order to understand it, I think it's best to kind of take a step back to some of the basic concepts we learned about immunology, probably in medical school for many of us. And I'm not sure about the level of learners that we have here today, but usually at Grand Rounds, there's a combination of med students, junior residents, senior residents, and staff. So the goal of the next few slides is just to try and get us all kind of on the same page in terms of an immunology understanding and the background of HLH. So to understand the pathogenesis of HLH, it's helpful to remember the different branches of the immune system. So in the diagram there, you can see on the left, we have our innate immune system, and on the right is the adaptive immune response. So in HLH, many of the key players are in the innate immune system. Specifically, two of the key cell types that play a role are one, your macrophages, and then two, your natural killer cells, or NK cells, both of which you can see in that box there at the bottom. So next slide, yeah. And so a bit more about those two cell types in case we've forgotten. So your macrophages, they are part of the innate immune system. They have a few regular roles that they normally play, which include phagocytizing or ingesting microbes. Then they can present microbial antigens to your lymphocytes to help initiate the adaptive or more specific immune response to the microbe. They also secrete many proteins, including cytokines, that then help mediate your host defense and inflammation. Your natural killer NK cells are also part of the innate immune system. They are a type of lymphocyte, and their regular role is to essentially recognize what's a healthy cell that's part of your body or what's an unhealthy, damaged, infected type cell, and induce apoptosis or cell death in the unhealthy, quote unquote, cells through a number of different mechanisms. So keeping these cells in mind, what happens in HLH? So in HLH, you get hyperinflammation or hyperinflammatory or a dysregulated immune state that's thought to be caused by the absence of normal downregulation by our activated macrophages and lymphocytes. So what specifically happens with those two cell types that we talked about? Our macrophages become activated and they end up secreting excessive amounts of cytokines, which can lead to severe tissue damage and ultimately organ failure. The natural killer cells then fail to eliminate your activated macrophages, which leads to even more macrophage activation, even more cytokines, and it becomes kind of a positive feedback loop, vicious cycle, leading to what's called a cytokine storm. Something that's not totally unique to HLH, but it does happen and is somewhat pathognomonic of HLH, is that your macrophages also phagocytize your host cells. So they're not just eating up the unhealthy, infected kind of bad cells, but they start actually phagocytizing your host cells, and that's called hemophagocytosis. And so hemophagocytosis is part of where HLH gets its name from. So it's the actual histologic finding of those activated macrophages engulfing your white cells, your leukocytes, your red blood cells, your platelets, and all of their precursor cells. And that's what's shown in this diagram off to the right here. So you can see it in a number of things, including hemolytic anemias, some infections, some malignancies, but it really is a hallmark of HLH. And that's where the hemophagocytosis part comes in the name HLH. And this is just a different depiction of the same thing for people who are more visual learners in case it was a bit complicated. But essentially, what you can see kind of in the middle of the diagram there is the natural killer cells on the left are not doing their normal job killing infected cells and other cells. Then in the middle, you can also see all the cytokines being released in the cytokine storm, causing increased macrophage activation. At the bottom, you can see the hemophagocytosis, where the macrophage is engulfing that red blood cell there. And then you can see that positive feedback loop depicted with the arrow on the right, kind of showing how with the hyper release of cytokines, it causes even more immune stimulation, and it really leads to this overly active immune response. So when we think about HLH, there's different ways to classify it. So before we get into that, I think Sarah will talk more about some of the clinical features, but it is helpful to kind of have a picture of some of the presenting features. So in general, it's a clinical syndrome that's characterized by fevers. You see pancytopenia, and you see splenomegaly. It can be caused by a number of different things. It's often categorized into primary versus secondary causes. So your primary causes is when HLH is driven just by genetic inborn errors of immunity, versus your secondary causes is when there's something else driving it. So either an environmental or some other acquired mechanism. So in primary HLH, you have autosomal recessive mutations in genes. And there's a number of genes that can be affected and kind of different mechanisms of that. But commonly, it's the genes encoding granuloexocytosis pathways, which then enable your natural killer cells and cytotoxic T lymphocytes to induce apoptosis in the target cells. Oftentimes, there is still a triggering factor in people with primary HLH. So the disease manifestations are frequently triggered by an infection. And this is something that often presents earlier in life, so in infants and children. In comparison, in secondary HLH, there's many things that can be the cause. We've divided it kind of into 3 subtypes and then other. So autoimmune diseases is one, and things that you think of are lupus, rheumatoid arthritis, or macrophage activation syndrome. Infections can also be a cause of secondary HLH, including EBV, which you'll note that that Sarah brought up, the patient did have this, as well as CMV and HIV, and then various bacteria, fungi, and parasites. Some malignancies can also cause it, including various lymphomas, some of your myeloproliferative neoplasms, and then various other metastatic diseases. And then there's a few other things that don't fit neatly into one of the 3 categories. So that would be kind of other states where the immune system can be activated or suppressed, so post-transplant or after cytotoxic or immunotherapy, and then post-splenectomy as well as another potential cause of secondary HLH.
So I'll talk a little bit more about sort of the general clinical manifestations of HLH and what these patients will look like oftentimes when you see them. I think, the challenge is that there's a lot of systemic manifestations, and a lot of these manifestations overlap with other disorders, which is what makes the diagnosis so challenging, and why we often diagnose it actually quite late into the presentation. And so some of the systemic manifestations can include sort of persistent fever of unknown origin. These patients might have sort of weird bleeding disorders, which might be due to altered coagulation parameters, DIC, or thrombocytopenia. So they can have erythematous, like papular bolus-looking rashes. They frequently will have cytopenias. We most commonly see anemia and thrombocytopenia on just routine outpatient blood work. And, sometimes these are the patients we see in the ICU or who, deteriorate quickly on the medicine floor and get transferred to ICU, who have shock NYG with pressor requirements. In terms of, a quick head to toe, outside of your systemic manifestations, from head, I think about altered level consciousness, it's very common. Patients can also have seizures. They can have syndromes that mimic strokes with cranial nerve palsies. They can have Perez-like syndromes with, MRI showing sort of posterior edema. They can have sort of profound and diffuse lymphadenopathy. They can have respiratory failure with an almost ARDS-like picture. They can have, body cavity effusions. So our patient had, bilateral pleural effusion, sort of NYD. They frequently will have hepatosplenomegaly and also features of hepatitis on their blood work. So elevated liver enzymes is one of the criteria that we look for. They can have renal failure. They can have hyponatremia due to like an SI-ADH picture. And then oftentimes they'll kind of have these like weird skin presentations, like rashes, erythroderma, petechiae, purpura. Around 25% of patients come with these skin manifestations. It's a bit non-specific, but it's something you kind of keep in the back of your mind. And, I will say that a lot of times when we think about HLH, we kind of think about like the extremes of its presentations, where, they come in with like a sepsis-like picture, there's multi-organ failure. But a lot of times they actually come in with these like stuttering, repeated presentations to emerge or to GYMRAC. And these initial signs can actually progress with sort of unexpected rapidity and severity. And sometimes that dramatic clinical progression is also very suggestive. So in terms of investigations and what you would sort of want to send off, so I think I like to think of it as, your initial evaluation and then your secondary evaluation, at which point you probably would involve sort of additional subspecialties. But I think on spec, on CBC is something you always want to order. You oftentimes will see pancytopenia or bicytopenias. We will oftentimes order reticulocyte to see the marrow response. We order the serum ferritin, which is what we classically kind of think of as being elevated in HLH. And we're often told, it's greater than 10,000. It's very suggestive of HLH, and sort of a few of its associated disorders. But I'll talk a little bit more into that and why it's actually not the case. And it's actually quite nuanced. Elevated triglycerides we tend to see as well. Elevated LFTs we see. And we usually always send up a hemolytic workup, including a DAT and LDH, which is often, as I mentioned before, elevated, very non-specific, but you can actually see it elevated in the context of like a microangiopathic hemolytic anemia from DIC and haptoglobin as well. We usually will always send off sort of your general coagulopathic parameters, so INR, PTC, D-dimer, and fibrinogen. And then we also send off a smear. And I will say that, the smear kind of helps you determine, could there be an underlying malignancy, specifically hematologic malignancy, but you can actually see schistocytes if there's sort of concurrent DIC present in these cases. So it's important that when you see that, not just to sort of entirely narrow your differential diagnosis to what we typically think of on your MAHA diagnosis, but remember that HLH can sort of still present like this. So, and then moving now more into sort of your further testing, if you have a high suspicion of HLH, and really what you're looking for is you're looking to confirm the diagnosis, but you're also looking to sort of understand, in adults, it's usually secondary to some underlying process. So a lot of your investigation is geared around trying to identify that. So we'll usually always send off quantitative immunoglobulins, SPEP, free light chains. We'll send off a peripheral flow cytometry to look for peripheral lymphomas. Infectious testing, these patients are usually so sick that we'll often send pan blood cultures and viral serologies. But I wanted to emphasize it's very important to send off EBV PCRs and not just your EBV serologies, because your EBV PCR actually tells you what the viral replication is and whether or not that's actually the driver for HLH. So for our case in particular, the EBV PCR was less than 1,000. So it's not very suggestive that was sort of the underlying cause. Oftentimes, bone marrow exam is sort of like one of the most important tests that you can do to help confirm the diagnosis. What you will tend to expect to see is, as Katherine mentioned, are these hemophagocytes. So these are macrocytes that have essentially phagocytosed or engulfed your red blood cells and your neutrophils. You can kind of see it in there. And this usually comes in 25 up to 100% of HLH diagnosis. And as Katherine mentioned as well, there's a lot of other causes of this. So just because you see hemophagocytes in the bone marrow doesn't mean that this patient has HLH. A lot of different things can cause it, whether it's blood transfusions, infections, autoimmune disease. Patients who are critically ill oftentimes will have this. And so that's important to keep in mind as well. And again, highlights how challenging this diagnosis is to be made. And so, the diagnosis of HLH should not be made just based on the presence or absence of hemophagocytosis. But if you do see infiltration of, bone marrow or other sort of tissues that you biopsy, it can help distinguish HLH from maybe other causes. In terms of additional testing, so a bit more nuanced testing, oftentimes we'll send off T cell receptor gene arrangements. That's to look for sort of your T cell lymphomas, which are very commonly associated with HLH. And oftentimes these patients are pan-scanned, like this patient was, and we're looking to see features of hepatosplenomegaly. Is it enlarged? So in this sample CT scan here, you can see that the liver is massive, the spleen is massive. It can also help to highlight signs of lymphadenopathy, which you also see in HLH, any other signs of malignancies like primary solid tumor malignancies, or even like lymphomas. You might be able to see it on the CT scan. There's more nuanced subspecialty testing that is typically sent more to sick kids. But, as for example, with this patient, like they were quite confused, disoriented. Oftentimes an MR brain is done, which you can see, sort of weird discrete lesions. You can see features of crest. You can see leptomeningeal enhancement. It's very non-specific again. And you can see CSF abnormalities as well. We tend to do an LP in these patients. Sometimes, part of the differential diagnosis we think about with HLH is like encephalitis. And so, sometimes you'll see some of the CSF abnormalities there. We tend to see more CSF pleocytosis, elevated proteins that's suggestive of HLH, but again, it's not very specific. And in your young males, coming with HLH, you want to think about genetic testing just because they are at risk of X-linked lymphoproliferative disorders. And I just want to highlight again that, 40 to 70% of HLH cases in adults are actually malignancy associated. And so you should always consider your investigations to determine if there's like an underlying occult malignancy present as the main driver. So, and it's important to identify the underlying cause because you need to treat the underlying cause and remove that trigger to actually stop the process of HLH, which Marina will also talk about a little bit more later on. And what I kind of wanted to highlight with HLH is that it's really, such a diagnostic dilemma. So we have the HLH 2004 diagnostic criteria, which I've kind of listed there. You can kind of see, cytopenias, fever, splenomegaly, elevated triglycerides, elevated ferritin. Those are all components of the diagnostic criteria. But the original diagnostic criteria is actually designed for clinical trials. And so it's not likely to capture every case of HLH. And you have to use the diagnostic criteria sort of in conjunction with your clinical judgment and the patient's history. It's also important to remember that not all of, HLH diagnostic criteria might be present initially. And so it's important to actually repeat your blood work, follow the clinical signs and laboratory markers of pathologic inflammation to, identify trends. So something that is, commonly used is something called an H score, which I put here. It just helps to sort of, give you a probability of HLH in an undifferentiated patient that you're seeing, and it's a helpful tool. So, as I mentioned before, HLH is such a challenge to diagnose because there's a wide clinical spectrum of presentations. It often leads to delayed diagnosis and delayed care. It oftentimes mimics your common infections, fever of unknown origin, hepatitis, encephalitis, or sepsis. These patients oftentimes have, chronic stuttering presentations. They come in repeatedly with fever of unknown origin, feeling unwell, general malaise before they actually, have rapid clinical deterioration requiring high acuity critical care. And it's because of all these reasons that you need a high index of suspicion because these signs and symptoms are non-specific and they're common and they overlap with other multi-system acute illnesses. So this is some of the differential diagnosis of HLH that I already mentioned. Some of them sepsis, oftentimes they can coexist. Your autoimmune disorders, your MAHA, your hematologic malignancies can present like this. You want to think about conditions that can cause elevated ferritin. So are they at risk of iron overload, infections, cancers, rheumatologic, inflammatory disorders like Still's disease is often associated, liver diseases, renal failure. And, with advent of sort of new immunotherapies, CAR T, checkpoint inhibitors can cause this HLH cytokine storm. So that's also on the differential diagnosis. So I kind of want to spend a bit of time talking about this marked hyperferritinemia and actually how useful it is. I think we're often taught, and there's this conception that, markedly elevated serum ferritin over 10,000, it's only, it only occurs in a few conditions. Your differential diagnosis for that, is very narrow, is what we're commonly taught. And that includes adult onset Still's disease, macrophage activation syndrome, and also the related HLH. But I wanted to highlight that a lot of our understanding of HLH and its diagnosis is actually based on the pediatric population, most of whom have familial HLH and not secondary HLH. And we sort of extrapolated this data to the adult setting. But what we're kind of seeing with sort of emerging evidence is that, elevated ferritin isn't that helpful or that specific. So in this study by Moore et al., it's a large sort of retrospective analysis study. It looked at 627 adults who have serum ferritin greater than 1,000. And sort of the average serum ferritin levels was in a 2,000s range. And the most common condition was actually malignancy and iron overload causing this. Very few, like 1% of patients actually had HLH, macrophage activation syndrome, or adult onset Still's disease. But I will highlight that this paper still sort of used a relatively low ferritin threshold of 1,000. This was a paper that was published actually in Blood, I think in 2019. And this actually looked at a higher ferritin threshold. So it looked at 113 total patients with ferritin levels above 50,000. It's very, very high. It was based out of MassGen. And they actually found that ferritin levels greater than 50,000 was actually seen most often in patients who have renal failure, hepatocellular injury, infections, and also hematologic malignancies. Of that 50,000, of that 113, around 19% had HLH versus MAS. And of those, it's kind of hard to sort of determine, which caused which, but, because HLH has such multi-system presentations, those patients also had, significant liver injury, renal failure, or both. And I think sort of the conclusion of this paper was that, although having, yes, a higher ferritin threshold increases the probability that a patient identified will have HLH, the majority of adults with this degree of ferritin elevation, like greater than 50,000, do not have HLH. So what does this all mean? And I think, when we think about marked hyperferritinemia, a lot of our understanding, again, is based on the pediatric population. We've extrapolated the data to adult settings. And I think it's important that we have to be able to exercise caution from generalizing our understanding of the disease from pediatric disease. And what we've kind of seen from some of the studies is that there's actually no ferritin value above which it's actually specific for HLH or MAS. And so you really need to be able to integrate a number of these different clinical features to confirm the diagnosis in adults.
So like Sarah and Katherine were alluding to, obviously diagnosing HLH can be very difficult, and it's something that we often struggle with, but it's important to try to figure out if the patient in front of us does have HLH, because delaying treatment for HLH can ultimately lead to irreversible organ failure or even death, depending on how many days they've gone without treatment. Next slide. So I'll start off by talking a little bit about primary HLH. And primary HLH is that familial one that Katherine was talking about earlier. And ultimately, this is the HLH 94 protocol that we often hear about. Next slide. So the HLH 94 protocol was first published in the early 2000s, and basically this was a study that took about 113 eligible patients that were less than 15 years old, and they were from 21 different countries, and they started them on the HLH 94 protocol, and this consisted of being treated with dex, cyclosporin, as well as etoposide. And what the study found was that at a median follow-up of 3 years, the estimated 3-year probability of survival overall was 55%. And then the 3-year probability of survival after transplant was 62%. So it found that giving the HLH 94 protocol was very effective, and it allowed them to reach the point of reaching transplant and improving the overall survival. And the whole premise of the HLH 94 protocol is really to try to suppress the inflammatory state that happens in HLH, like Katherine was talking about earlier, and getting rid of some of those offending cells, the T cells, and ultimately getting them to transplant. And that's the ultimate treatment for familial or primary HLH. And on the side Here you can see what the protocol looks like. You could see that at the bottom there, it talks about how many weeks they're usually on it. So it usually goes on for 8 weeks, and then there's continuation therapy and maintenance therapy after that, or they are on transplant at that point, and then they get a tapered dose of steroids as well as etoposide and cyclosporin. Next slide, please. So now I'll talk a bit about secondary HLH. And this, like Sarah was saying, the most important part is to treat the trigger. Next slide. So usually, like you guys know, if it's a rheumatological disorder, you would give them steroids, you would do whatever is specific for that disease, the rheumatological disease that they have, and treat that disease. And ultimately, you should see a bit of improvement. You should see improvement and then improvement in the HLH. If it's malignancy, you would do a disease-specific therapy in that sense, and may or may not add etoposide if it's appropriate, and then ultimately go on to doing Dex and cyclosporin, and adding that on as well. If it's an infection, you use antimicrobial therapy. If it's EBV in specific, they've been shown to use rituximab first, and then if it's refractory to the antibiotics as an infection or the Ritux in terms of EBV, then they go ahead and use HLH94. And then ultimately, if there is any refractory disease, even if it's a secondary HLH, they do go ahead with stem cell transplant in some of those rare scenarios. Next slide. So this was a study out of the Mayo Clinic that basically included 62 patients, and it was trying to look at what the outcomes were like in patients with tumor-associated HLH versus those with non-tumor associated HLH. And ultimately, you can see after these patients received the HLH94 protocol, whether if they were non-tumor associated HLH, so a secondary HLH not due to malignancy, those patients had a better overall survival compared to those who were tumor associated. And ultimately 41 of the 62 patients had died after a median follow-up of 42 months. So although this is, although HLH94 protocol is what we currently have and how we treat a lot of our patients with refractory disease in the secondary HLH phenotype, it's still not the greatest for these patients. Next slide. So, and then of course, on top of, treating the specific therapy, treating them for their specific diseases, you also give them pressors or broad spectrum antibiotics. You kind of do supportive treatment for the underlying disease and the underlying symptoms that the patients are having. Next slide. So what's next? And like we mentioned, we've seen the outcomes of the HLH94. It's made a big difference. It's allowed patients to really reach the point of being able to get transplanted if needed. It's increased the overall survival of patients, but it hasn't been perfect. And right now, there's lots of trials going on. One of them is really looking into alemtuzumab, which is an anti-CD52. And basically, there was a study done. It had 22 patients, and it looked at these patients who received standard therapy for about 8 weeks prior to receiving the anti-CD52. And the treatment immediately prior to the alemtuzumab was dexatoposide and cyclosporin, which was the HLH94 protocol. They then received a dose of 1 milligram per kilogram alemtuzumab, and 14 of the patients, of the 22 patients, experienced an overall partial response. And the study defined a partial response as at least a 25% improvement in 2 or more of the symptoms or laboratory markers of HLH 2 weeks following alemtuzumab. And then 5 additional patients, so 5 of the 22, had a 25% or greater improvement in at least a single symptom. And ultimately, the study showed that 77% of patients survived to undergo transplant, which is the ultimate goal and where we're trying to get our patients to. the JAK inhibitors are also being studied right now, and they're currently in clinical trials. And really, the idea is that there's uncontrolled activation of T cells and macrophages, which results in cytokine release. And JAK can transduce these signals upon binding of various cytokines to their receptors. And JAK inhibition can be beneficial in inflammatory conditions, but this is still being in clinical trials and hasn't really been used yet. Next. Lastly, I wanted to talk a little bit about anakinra, which is an interleukin-1 antagonist. And there's a couple of studies that have been looking into this. First, there was a retrospective analysis of adult patients diagnosed with secondary HLH for about 10 years, a 10-year span, and they received anakinra and high-dose steroids. And some of them received the HLH-984 protocol, and then others received only high-dose steroids alone. And what it really found was that the cumulative incidence of response at the 30-day mark was 83% for patients who were treated with anakinra, 60% for those on the HLH-94 protocol, and 36% for those treated with steroids alone. And then the relapse at 1 year was 50% for those who were on the HLH-94 protocol, 33% for those on steroids alone, and then 0% for those on anakinra and steroids. And then the overall survival at that 1 year mark was higher with those who were receiving anakinra compared to the HLH-94 protocol, yet it wasn't statistically significant. There was also another study, which was a multi-centric retrospective study, which basically included 21 adults who had secondary HLH. And it found that anakinra was effective in about 90% of the patients with fever resolution within a median of 1 day. And at the 7-day assessment, it found that the CRP as well as the ferritin levels decreased significantly. And lastly, there was another study that had included 16 adult patients with secondary HLH, and they were treated with anakinra. And it found that overall survival among the patients with who were initiated on anakinra, the median was about 1.7 months, but that in terms of rheumatological causes of secondary HLH, those patients, it was 75% of overall survival, whereas only 17% of patients with other provoking factors survived. So actually at St. Joe's, they've been using anakinra for more of their CTD cases, and they've seen some good outcomes with that. But anakinra hasn't, as you guys can see, there hasn't been any large trials or studies done yet, and so it hasn't been used more. Next slide.
So kind of going back to our case. So this patient was admitted to ICU. Hematology was consulted. There was a suspicion for HLA as a possible trigger. There's a question, could this be lymphoma? Was sort of this Warburg effect or the type B lactic acidosis? A bone marrow aspirate and biopsy was completed, which actually was eventually diagnostic for diffuse large B-cell lymphoma isolated just to the bone marrow, which made it stage 4 irregardless, and resulting secondary HLH from his lymphoma. The patient was started on dexamethasone and then R-CHOP, so basically R-CHOP with etoposide, so a little bit of the component of the HLH-94 regimen. And he actually had a great response, and he was transferred to the hemonc ward in stable condition with that, improving indices in his blood work. So in terms of some of the key takeaways, so early recognition of HLH prevents, irreversible organ damage and death. There's a high mortality in the absence of treatment, so don't delay treatment of high suspicion, especially, if it's just sort of starting off with empiric steroids. And adult HLH, again, is a heterogeneous disease, and there really isn't a one-size-fits-all approach to diagnosis and to management. Thank you so much. We also want to thank Dr. Mithoowani. I don't know if he was able to make the grand rounds, but for reviewing our slides as well.
So thank you so much for this great presentation. So really evidence-based and very educational for all of us. So I'm going to open the floor for any questions if you have. Use the Q&A or the chat, or raise your hand and I will be able to give you some mic access.
so, 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 so.
Good. In the meantime, I have a question. Right, you talked a little bit about familial HLH, right? But I was wondering, what is the current recommendations in terms of screening in asymptomatic family members?
So.
That's a great question. I'm actually not entirely sure because it's largely in pediatrics, like HLH. So I actually don't know too much about it, but I can't imagine that they would be. I'm actually not sure. That's a great question. Like, I don't know if they would test for a certain like genetic, like mutations, or if it's more just sort of symptom based and presentation based.
We have a question here in the chat. So, what is the evidence of PLEX in those patients for management of HLH?
So.
Yeah, I was going through this in the literature. There are some studies that talk about, if a patient is being transferred from a community center to a more academic center, and they have Plex available, but they don't have some of the other treatment protocol there, then it could be initiated more in the early stages of treatment. But there hasn't been anything, at least that I found, although it would be something we could look into about later on using it once they have the HLH94 protocol available to them. It's more something that's used earlier on during transfer in more community settings.
So.
Yeah. So, just for this particular case, so what was the timeline between diagnosis and start treatment?
So
for this particular case, I think between diagnosis and treatment, I think was probably like less than 24 hours. So we got the bone marrow biopsy results back, like preliminary, probably back within like 8 to 12 hours, like some prelim results, and then we started like DEX the next day. And then our CHOP very quickly, like the day after.
We have another question in the chat. So, is there any specific patient population in the world that have higher rates of familial HLH?
So.
What I found on this was it looks like a lot of the data has come out of Japan, and so for some of that information, like it's unclear, is it higher rates in Japan because they're only studying within Japan, or is it really kind of the genetic predisposition there? It does look like in the research that I looked over, and to be honest, I haven't looked into this that much, but what I did see when I was just reading a bit about the epidemiology is that there do seem to be different mutations in kind of like different genes that are more common in various ethnic populations. But other than kind of the predominant research that has been done in Japan, there wasn't one specific like ethnic population that I found that seems to have higher rates.
Any further questions from the audience?
So
we have a question here, so then open the mic here.
So
your mic is open.
So
hey guys, great presentation. Sorry I came in a little bit late. I just had another meeting. So I apologize if you already answered this. But in the rheumatology world, we see a lot of MAS, like macrophage activation syndrome. And I often wonder, other than steroids and anakinra, is there a role for other adjuvant therapies? Do you have any data on that, or?
So
I think it's very hard because I feel like everyone approaches it like a little bit differently. Like, is your question specifically around rheumatologic associated?
Yeah, exactly. So like macrophage activation syndrome are specifically rheumatologic associated HLH. Yeah. And there may not be a clear answer on this. I don't know. I get different answers from different game staff when they're on. But I'm just curious if you guys found any data for that.
So
The most that I've seen, at least, I'm not sure about Sarah and Katherine, but I think the most that we've read on was really anakinra, and speaking to our supervisor as well, that's what he has mentioned as well. But nothing else, unfortunately, came up for us.
I think it's also like important to also treat the underlying rheumatologic condition as well. If it's associated with RA or like lupus, to treat the underlying condition to help remove that trigger.
Thank you. We had it, just to give you an example. I mean, we had a case about a week ago. It was a middle-aged woman with lupus, raging disease, very clearly had macrophage activation syndrome. So we started her on pulse dose steroids, and then the question became, now, do we give her cyclophosphamide? Do we start using etoposide? Where are we going with this? And I feel like it's quite a gray area, and we don't have a clear answer, like you guys said. So anyway, thank you.
So
we have another question about the mic.
So
hi, this is Reza Mirza, Dr. Ladak. I just wanted to put a quick comment in based on my limited experience, of course, given how rare this is. With lupus specifically, I found anakinra has turned off the disease in a few cases, right away. ICU patients having seizures. And then there was a recent case we had at St. Joe's where the patient actually had an HLH-specific mutation. It was kind of questionable whether the mutation was pathogenic because it was quite common in the population, but it was a known site associated with HLH. In any case, we gave that patient anakinra as well, and they passed away, unfortunately. So I don't know if it's. I think that kind of speaks to some of the data that was presented, where there may be a better efficacy in rheumatologic induced HLH. Maybe it's more IL-1 mediated, and that blockade can help stop things. And in terms of other agents that I've seen used, I think it's more like the chemotherapeutics when it's a primary HLH that I've seen, like the etoposide pathway. And then when for ours, the only other thing I've added, again, just limited experience. I can't give any data, and there's no trials on this, but I think there's some retrospective data for calcineurin inhibitors like cyclosporin or tacrolimus. But yeah, it's kind of a gray area.
So
Thank you, Dr. Morrison.
Thank you so much to the audience that made the questions. And I think we are at 12:52. Again, excellent presentation, very educational and interesting overall. Okay, so we can finish early. We have some time off. And thank you so much again.